Okay. Okay, great. So the bottom line with adjustment disorders is, although they tend to resolve by themselves, the consequences of poor behavior or unhelpful behavior whilst you have an adjustment disorder can have long-term effects. Trauma, I won't spend too much time on trauma, but trauma is not what you might describe as having too many emails or a difficult time. It's a situation which is above and beyond normal experience and tends to involve real or threatened death, serious injury, or sexual violence. The important thing to say here, other than this picture isn't real, is that if there's a traumatic situation, two people in the situation can have very different experiences. So the diver here will have a very different experience to the experience of the pilot, even though they were both involved in the same event. So you can't just make the assumption if one person's okay that the person standing next to them is going to be okay too. And as I said, this is what a potentially traumatic event is. Real or threatened death, serious injury, or sexual violence. And you can experience it either directly, witnessing it, finding a very, very close relative, normally one's son or spouse, dies in a horrific and violent way, or importantly, in the course of professional duties. So people exposed to trauma regularly on a day-to-day basis. After a single trauma, actually, most people tend to recover. And this is the time since the trauma down here. This is the percentage of people who have symptoms. You wouldn't diagnose PTSD until at least a month after a trauma. And you can see that in the first month, you get lots of people with lots of symptoms. Most of those people recover. And you're really left with here about 10% of people who have a persistent problem. This is what's called a naturalistic study, in the sense that people after a trauma weren't treated. This is what naturally happens. Most people recover by themselves. You're left with this percentage of people who don't recover. And these are the people who have probably got PTSD and need treatment. However, lots of professions, child social workers, healthcare, emergency services, don't just get these big incidents. They also get lots of incidents on a daily basis that gradually erode away at someone's mental health. And then what happens is something small happens, which is they change office, or they get told that they can't do a small thing. And that seems to make them really upset. And the reason they get very upset and very distressed is they've been going gradually downhill for a while and no one spotted them. And these smaller traumas are called type 2 traumas. And these are the ones that chronically we get exposed to at work. It's a really important topic for those organizations that have trauma as part of their routine day-to-day sort of activity. And let's say healthcare and social work are good examples. Alcohol and drug misuse. Generally, we think about it in three ways. There's what's called hazardous use, which is too much, so drinking above the limit, for instance. When it moves to harmful use, that's when you are having psychological problems. So, for instance, you're depressed or anxious because you're drinking heavily, or you get into physical problems, maybe you get into fights, maybe you fall over, maybe you develop some physical health complications, gastritis because of your alcohol use. And then you get dependency. And dependency is when you lose the ability to control your drinking. So you crave for alcohol. When you have one drink, you then have 7 drinks because you can't stop. Don't know if any of you have heard of the CAGE questionnaire. It's a very simple screen that you can use in a clinical setting. And if you score more than 2 out of these 4, then you may have an alcohol problem. C stands for, have you felt that you should cut down recently? Have you got angry when someone talked about you cutting down? Have you had guilt about how much you've drunk? And have you taken eye openers? And eye openers are those drinks that you apparently have in the morning. I'm glad to say that that's not something that I've done too much. So more than 2 out of 4 of those is, yeah, someone might have an alcohol problem. And then there's more serious mental illnesses. So we've now moved beyond what we call common mental health disorders. Psychosis, which is the loss of contact with reality. Not many people with psychosis are going to be working, but there are some, and we should encourage more to work if it can be done safely. The 2 most common diagnoses here are schizophrenia and bipolar disorder, which used to be called manic depression. Probably about 1% of the population might have each disorder. And these sort of people are, when they're well, can have a perfectly good good level of functioning, but they need to be managed carefully, because when they go into a psychotic situation, that their behavior can become very unpredictable because they've lost contact with reality. Um, More and more commonly talked about now, for good reason, are neurodevelopmental disorders. Up to 20% of the population at work will have a neurodevelopmental disorder, and that's getting to the point where I think it's just part of the normal variation of human beings. The two most common ones spoken about are autism spectrum disorders, ASD, and attention deficit hyperactivity disorder, ADHD, which is becoming more commonly diagnosed now. It can get absolutely diagnosed in adults. We recognize that that's the case. You've also got dyspraxia, dyscalculia, and dyslexia as well as part of those conditions. And then there's eating disorders, which affect men and women, and when they're severe, can have a really terrible effect on people's physical health, as well as their ability to do their job well. And the important thing here is occupational health physicians have got a real role to play in translating what secondary services are saying into a workplace setting, because often people who are spending a lot of time dealing with, say, people who've got schizophrenia may not have a very good understanding, those clinicians, of what it's like to be in a particular workplace. So the OH professional really has a big role to try and translate that information into what goes on at work. You've heard of presenteeism, I'm sure, which is the being at work when you're not present in body but not in mind. The important thing there to remember is that this actually is a far bigger problem for industry than absenteeism, and it's particularly important in safety critical situations. So, part of the Germanwings plane crash of 2015 was a very well known example, but there are lots of safety critical occupations out there, and I think it's really important that when you're assessing someone's mental health and you've got a very well-meaning but not occupationally aware mental health professional who's saying, "Oh yeah, send Neil back to work. That's absolutely good. It'll be really good for him." It's your job to think, yes, but can he do this safety critical work? And when it goes wrong, these things can go wrong in spades and affect not just the individual, but many people around them. So we absolutely need to think about safety critical workers, and they need a higher standard of mental health, as the driving licenses, type 1 and type 2 driving licenses reflects in that sense. So common mental health conditions are common. They're pretty well understood. Why don't we just get on and treat them? Because in a physical health setting, someone gets an injury, they go to hospital, they get back to health, and they get back to work. That's pretty simple. How long this takes depends on the nature of the condition. Surely the same would go for a mental health condition. You just go and get some treatment and you go back to work. But as we know, there are lots and lots, and I won't go through them all, of different barriers. And I'll make the slides available if you want them, by the way, to why people wouldn't readily go from having a mental health condition and simply get better and go back to work. They worry what people will say. They worry about their career. It's not always easy to get help. Sometimes they can't connect with the therapist, who doesn't seem to understand that they're trying to do a job and the therapist is just thinking about symptoms. They're concerned about colleagues. So the loss of self-esteem and confidence. So there are lots of barriers that act to prevent people with mental health problems coming back to work. Now, these barriers are overcomable, but you have to think about them and not just forget that they're there in the first place. And of course, one of the biggest barriers often talked about is that of stigma. And stigma comes from a mental health point of view anyway. It comes from three kind of main areas. It's knowledge about a condition. I don't want someone who's depressed in my workplace because they're going to make me depressed and do a bad job. Well, that's not necessarily true. There are people in a workplace who are depressed right at this moment, because it's not an uncommon situation. People have prejudicial attitudes, thinking that people are less worthy, and then they behave in ways that discriminate people. I spent a lot of time doing work in the military and also research work with the military. And actually, military personnel are not as discriminatory as you might think, but what they are worried about is being in a combat zone with someone who is not able to look after their back. And that's a perfectly sort of reasonable view. You don't want your pilot to have a mental health condition either. Not, or at least not one that's serious enough to impact upon their behavior. And so the key thing here is that stigma often comes from people not knowing enough, holding attitudes that are outdated, and behaving in a way which actually doesn't fit with the evidence that's around us. This is a study we did some years ago with journalistic managers, and we asked them about why they might not seek help for a mental health issue. And what they told us is the most common reasons they wouldn't seek help is they worried about being given responsible jobs. I mean, they want to go to the exciting stories. They don't want to get just put on the gardening program. They want to be trusted by their peers. And also it's embarrassing to ask for help. And this is an older paper. And I think one of the things that we're seeing over time is that these attitudes are improving. So I mentioned the adult psychiatric morbidity study, which I think is here, but I'll tell you that in a second. We know that back in 2007, roughly 1 in 4 people in the UK who had a mental health problem were seeking any help. And by 2014, that 1 in 4 had gone up to 1 in 3. So that is an improvement, but it's not a huge amount of improvement. And this is from the APMS study as well. And this is looking here at military veterans. And what we thought we would see is that military veterans who have PTSD would be less likely to seek help than the rest of society. But we didn't find that at all. We found that actually, whether you were a military veteran or not, about 2/3 to 3/4 were not seeking any help at all. And in my occupational practice, I go around and see patients from lots of different organizations, but also do training and consultation with organizations. I know when I go to construction work sites that construction employees and staff and contractors say, oh, in construction, we don't talk about mental health. If you go to the government departments, they go, oh, in the government, we don't talk about mental health. If you go to the military, they go, oh, we don't talk about mental health. If you go to the police, they say, oh, we don't talk about mental health. Not talking about mental health and being afraid to get help is not restricted to any one occupational group. And although whoever you work with, they may say, oh, we're particularly bad in our organization. My experience is most organizations think they're particularly bad. And actually what you need to realize, what the employers need to realize, is this is as much a societal issue as it is any particular organizational issue. So we know work can be good for mental health, but it can certainly be bad. Common mental health disorders, unsurprisingly, are common. Productivity can be affected even when someone's not formally ill, when they've got lots of symptoms. And the most problematic thing is when people become quite unwell, they don't necessarily seek help early enough. So we, instead of looking at why people didn't seek help, we decided instead to do a study, this was with military personnel, of why people who came and got help, how did they get there? And what we found is that the 2 most common reasons that shift someone from, I'm not seeking any help, it's too embarrassing, no one could help me, to actually now I'm seeking help. The 2 most common reasons were a significant other giving them an ultimatum. So it often was a spouse, but it could be a boss, it could be a best friend. And they would often say, you know, Neil, if you don't go and seek help, then I'm going to tell your boss. Or if I'm your wife, I'm going to leave you. I've had enough. Or if you're someone's boss, we're going to have to put you on sick leave. So those ultimatums often are what shifts someone into, okay, I'll go and get help. Or unfortunately, what we also find is something dramatic happens. So they make a terrible mistake at work, or they get involved in a fight, which is incredibly out of character, or something, a mistake happens, something really bad happens, and that then shifts them towards getting help. And of course, the real problem there is that if only you could have shifted them to get help earlier on, then you could have avoided that bad thing from happening. When people do get help, where do they get help from? This is another military study, but we've got data which is extremely similar in healthcare settings. I just haven't got onto a slide yet. We asked people in the military, who did you speak to about your difficult deployments? 97% of people spoke to people just like them. So wearing the same uniform, wearing the same shoes, speak the same language, have the same experiences. Most people speak to their colleagues first about their psychological difficulties, even though they might not describe them as mental health problems. Only 8% of people went to mental health services. So if you've got a welfare service, if you've got an occupational health service, you might have an employee assistance program. All of these things are good, but most people seek help from their colleagues in the first instance. And they also tend to wait until the last possible moment to seek help. And that's why, you know, if we can only get them upstream, then hopefully we could prevent those critical situations from occurring, which are the ones that lead them to get help in the first place. So just want to talk now sort of briefly about different ways to try and prevent or improve organizational mental health. Policy is important. I don't spend a lot of time on policy because policies tend to kind of represent strategic ideas, and they often don't get translated. So there's many examples in employment tribunals and in court cases where a policy says, oh, look, we should be doing this. And the claimant or they is often saying, yeah, but you didn't do that. So I think policy is quite good for setting culture. What does it say that we want to do? But I wouldn't put too much into policy, because policy sometimes can wrap you up and you get caught out for not obeying your own rules. What it can do, though, is to clarify responsibilities. So if I'm a train driver, my organization needs to look after me. But at the same time, if my mental health is poor, I need to tell my organization, because otherwise I may end up creating a bad accident, which will affect lots of people. So there is a joint responsibility in individuals' mental health. It's not all about the organizations there to care just for you. Individuals also have a role to play. And it may also detail support options. You know, maybe you've got an EAP or occupational health counselors, whatever else. We know one of the things that's probably most important at work is camaraderie, is having buddy support. So excellent evidence that if you feel that your colleagues around you are there for you, are supportive of you, have got your back, then you are much more likely to enjoy good mental health. But the best or the most important and influential relationship is the relationship between you and your immediate supervisor. So not what the chief executive thinks or the senior manager, it's the shop floor supervisor, the person who day to day is influencing your life and your workload. This is data from military personnel in Afghanistan in 2010. We asked people to rate their immediate leader, their immediate supervisor. Did the immediate supervisor embarrass people in front of others? Did they take on extra duties to make themselves look good at the expense of others? Did they treat all members of the unit fairly? And did they show concern about the safety, physical and psychological safety of team members? If people scored 3 or more about their supervisor, we said they had good leadership. In this sample of about 1,500 troops in Afghanistan, just less than 3% of them probably have PTSD. But if you felt your immediate supervisor was good, you had 1/10 of the rate of PTSD or probable PTSD compared to thinking your immediate supervisor was bad. So by having a supervisor immediately above you who you felt was looking out for you made a huge and very positive difference on your state of mental health. This is a study from Australia. Firefighters. It was a randomized controlled trial where they trained up some fire station managers in how to have a psychologically informed conversation. They gave them listening skills. They looked at sickness absence costs in the 6 months beforehand and afterwards. They published it in a UK journal, in Lancet Psychiatry, which is a very good journal. And they found that every pound invested in that management training saved £10 in sickness absence over the next 6 months. So a 90% reduction in sickness ill health costs by having a supervisor who felt confident to be able to speak to you about your mental health. So when COVID kicked off, we set up a scheme similar to that for training up healthcare professionals, and we developed this process called React, which was at that time a 1 hour online doing Zoom active listening skills training for NHS supervisors. And over the 1 hour period, we got them to kind of understand how to recognize, engage, actively listen, check for risks, and then talk about a specific plan. So we gave them a structured schedule about how to do that over about 15 minutes. We gave them a 5-minute demonstration or so, took a few questions, and then importantly, we got people practicing in the breakout rooms how to have these React conversations. So any sort of mental health skills training that you want to do has to involve an element of practice. If you just merely tell people how to do things and leave them to go, it very rarely translates into a positive effect. And we published this in Occupational Medicine, of course. And we found that with this React, this 1 hour online training, bite-sized training, before the training, over half of the supervisors didn't feel confident to speak with support and identify individuals with mental health problems. 1 month after the training, nearly 85% of managers felt confident. So that's a bite size. It's not asking for very much training in order to really bolster supervisors' confidence to speak about mental health difficulties. Another really important approach that supervisors can take with staff is to follow what we call the PIES principles. And these are what you do when you have an employee who is stressed, who's got difficulties. What are the principles of how you approach managing them? This was a study from the Israeli military published in the American Journal of Psychiatry, which is a good journal. And what they looked at here were Israeli military personnel who back in 1982 from the First Lebanon War. And these were troops who developed stress reactions. So they were not functioning well because they were very stressed and very frightened. They used the PIES principles. They followed them up for 20 years. And you're probably aware you don't get many 20-year follow-up studies. And they found the more the PIES principles put into place, the better people were 20 years later on. So the first principle is the principle of proximity. And what that says is if you've got someone who's got a difficulty at work, don't just send them home. Instead, you want to try and keep them close. You want to increase the support available to them, and you want to temporarily decrease the pressure they experience. So don't send them out on a single job, buddy them up with someone else, reduce their pressure for a while, take them away from whatever the front line, the most intense work you do, and that will really help them have a chance to recover. If you send them home, they worry what people think of them. They feel that no one really cares. They might not have good support because we already said that people like speaking to each other. Immediacy says, if you see someone going downhill, don't just let them go downhill. Instead, intervene early, have that active conversation, have the expectation they're going to be okay. We're going to help you. And if you don't get helped, we're going to make sure you get to the right care. And then simple things make a big difference. If you've got someone who's really worried about how to use a particular piece of equipment, they don't need cognitive behavioral therapy for their anxiety. They need someone to mentor them to show them how to use that piece of equipment. Just worth saying, one of the things often discussed is about personal resilience training, which is about this idea of giving people mindfulness or yoga or enhanced coping skills. And the overall evidence of this, even though NICE do recommend it, is that they don't appear to make much difference. So I'm not saying that they're bad things, but I wouldn't rely on individual level resilience training as an approach for how you're going to bolster your organization's overall resilience. And the reason they don't work isn't that they're ineffective. It's that if you give it to 1,000 people, probably only 30 people use it. And those 30 people get a lot out of it, but the other 970 just don't use it really. And that's why when you try and roll these things out in big organizations, they don't tend to have the effect that you want. Very briefly, because of time, I'll just mention screening. The message really here is you could screen people before they go into a job. So you can't go into this high-pressured role until you screen them. And overall, the evidence is that it doesn't work. That actually, when you try and screen people, you screen out people who are perfectly good, and you let in people who, unfortunately, are going to develop problems because you can't work it out. This is a good study, again, published in OCMED, from the Australian police. And basically what they did there is to use the MMPI, which is a really comprehensive screening tool. When people joined the police, they followed them up for 7 years, and they found this comprehensive 350 item screening tool predicted absolutely nothing. Not useful. So the idea of pre-screening might seem very seductive, but it doesn't really work. And the idea of post-screening, so you've been exposed to a big trauma, something terrible's happened, there's been a suicide, there's been a terrorist attack, an explosion. The American troops get screened regularly when they come back from deployment. And the long and the short of it is it doesn't work. We did a study using screening in the British military, funded by the Americans. We screened about 9,000 troops who came back from Afghanistan over 18 months. And when we compared those who were screened and those who weren't screened, there was no difference in the outcomes of their mental health. The idea of trying to screen people, give them questionnaires, it sounds seductive, but it just doesn't work. The only way that we found that it seems to work is where the screening is done by someone completely independent. So it's not your employer, it's by the health service. And after the London bombings, there was a good study done showing that if you screen people with the health service doing it, then most people, again, don't respond to the screening, but the ones that do tend to be quite unwell. So it's a way of picking up seriously unwell people, but it's not a way of trying to look at a whole population and say, are they fit or not? Just aware of time and want to leave some time for questions. One way that does make a difference, and we've mentioned this already, is about having good peer support in place. And one way of doing this is through having a formal peer support program. I need to say a conflict of interest here. I do this TRIM, which is a peer support program, is something that my company trains. So I'm telling you about it generally. You don't need to buy TRIM. It's just an example. The idea here is that because we know people in the workplace speak to each other, then actually, why don't we try and give those people in the workplace the basic skills to identify who's got a problem and some basic ideas about how to support them. What you do through a TRIM training program or through psychological first aid or whatever peer support training you do is you're trying to give people the skills to identify individuals who've got problems. You're not trying to turn them into counselors or therapists. And the overall benefit when you have a peer support program in place is that it makes a substantial difference. It tends to spot some people who have got problems and get them into help. And it also creates this sense that actually the organization's looking out for me. And we show that that has led to increased productivity. And we've done about 15 trials now at TRIM. And so as an example of a peer support program, we're pretty confident that peer support is a good thing for organizations to have in place. And then lastly, when you identify someone who's got a mental health problem and you send them to a mental health clinician to get better, what's really important here is that mental health care has to focus on return to work. So I won't read them out, but you can see the bits I've highlighted here in two relatively recent papers. Is that people who go to a clinician, a mental health clinician, who says, my job's to get you better and to get you back to work, are much more likely to get to work than some clinician who just says, I don't do work, I just get you better. So you want to make sure that any mental health services you use have return to work as a focus. And I think one great role for occupational health professionals is including that return to work focus. So if the NHS clinician doesn't do return to work, then you can work alongside the NHS clinician and keep that return to work focus going through communication with the clinician and with the individual. But you've got to have a return to work focus to your mental health care, and that's much more likely to get people back to work. So just finishing on practice points, when you're speaking to people, employees who might have mental health problems, I would focus very strongly on rapport building. You've got to get them to trust you a bit before you ask about conflicting information. So when they tell you that their boss is horrible and doesn't do anything right and it's horrible, don't just go into, well, your boss tells me this, that, and the other. Instead, build the rapport with them. And then to say, look, I wonder if you can help me because I'm a bit confused. Why would your boss say this? Because you need to ask the questions. Don't just treat people who are unwell. Look at the workplace environment. There's no point giving someone 12 sessions of cognitive behavioral therapy if they still perceive their boss is treating them unfairly, because it won't make things any different. The best thing you can do from an organizational point of view is to not wait till people come to you, is to do everything you can to advise, intervene, and be seen as a resource for your organization so that they'll consult you. So they won't put in a mindfulness program by itself, that they'll try and put in place things such as, say, active listening skills for supervisors that are likely to make a much bigger difference. And you don't want to be seen as a last resort. You don't want HR to send someone to you, once everything's gone completely wrong, because it's much more difficult to get them better, and it's much more difficult for you to help the individual and the organization lead to a positive outcome. If you can see them early, you're much more likely to have a positive impact. And the last thing I'd say is don't rely on all mental health clinicians to have a return to work focus. Many clinicians would just see their job as being, I'm just here to treat symptoms. And that might not be helpful. We're trying to change it, but it's worth knowing that. And so really, there's lots of good reasons to proactively support staff. You want to provide treatment for a few, but mostly early intervention makes most of the difference if you can. When you make reasonable adjustments for people at work, you shouldn't perpetuate mental health problems. So if you've got someone who's very avoidant and very phobic and you say, well, you can work from home as much as you want, that might seem like a good idea, but they're not going to get better. So you want to work with them to say, to work at home until you start your therapy. And then as you start your therapy, we want to get you to come more into the workplace. You want to help people overcome problems and not perpetuate them. Follow the evidence. Many well-meaning HR professionals might bring in these interesting programs. You can act as a place of evidence saying, well, we should think about this more widely. And this is a cheesy phrase to end on, is that within organizations, resilience often doesn't lie in individuals, but it does lie in the bonds between them. So that's me, and I'll stop sharing and I'll happily take any questions.
Thank you so much for this excellent presentation. I really, really enjoyed it. Many thanks, especially the section about cost effectiveness and the Australian study. I didn't know of that. Yes, for each £1 they spend, there was about £10 return, because this is something which is absolutely lacking in the current practice at the moment. So many thanks for everything. I appreciate it. So about the questions, let's just start with the first one, which is about ADHD and the current shortage of medication at the moment. Is there anything OH can do? What do you think?
So the current shortage, and there is a shortage around, is on stimulants. So often on things like Ritalin and dexamphetamine, prescribed dexamphetamine, I would say. But there are other medications that can help as well. So I think from an OH point of view, you want to make sure that your employee is seeing a clinician that understands ADHD. So most GPs wouldn't start someone on ADHD medication, although some GPs might. So if the individual can't get hold of Ritalin, or the GP says they can't get hold of Ritalin, I mean, it is available, and there's no two ways about it. It's just more difficult. But there's also a drug called atomoxetine, which is a perfectly good non-stimulant base. And also the evidence is also antidepressants can make a difference as well. And often what happens with people who have ADHD is their self-esteem gets impacted because they can't concentrate, they become depressed. And actually, if you can treat the depression, that can make a positive difference. And then in terms of workplace adjustments, people who have ADHD are very restless, and they sometimes have difficulty in concentrating, but they also have a great ability to have what they call hyperfocus. So that once they get into something, with children, it might be sort of computer gaming, they then almost have this kind of blinkered vision and don't see anything else. So the question is, how can you alter their job to try and suit their symptoms as best you can? And I have to say, stimulants are great, and where they make a difference, they can make a huge difference. But also, certainly with children and with young adults, there is this whole idea that you shouldn't necessarily take them forever. What you should do is take them when you need to. So if you've got an exam coming up and you need to study, absolutely, your stimulants are great there. But if you're off on holiday, then you don't need to take them during the holiday time. And so I think from a workplace point of view, can you use what is available in terms of medication, and also workplace adjustments to improve someone's ability. But I think adult ADHD is here to stay and will become a more common difficulty over time.
Great, many thanks. So mainly by perhaps adjusting work activities, we may be able to help patients at the moment. Great, many thanks. The next question is, okay, I'll read that for you. What do you think about ASD treatment via gut bacteria adjustments or music therapy?
Okay, so ASD is obviously, just as it says, it's a spectrum, and the key thing is that for years we have thought about autism as a diagnosis before ASD as being the people at the far end of the spectrum, and many of those people, have a whole range of other difficulties as well. And so what happens is, as we begin to know more about ASD, then obviously there are more people who are at the milder end of the spectrum who are also going to be quite rightly able to attract that label. So what does that mean for them? Well, it means that management for that is that there are some work situations that are really well suited for people who have the mild end of the ASD spectrum. For instance, if you go to people in some bits of the security services who look up, IT and sort of communications and thing, they're crying out for people with those skills. There are some jobs out there which have incredible attention to detail, where people who have ASD are probably better off than people who don't. So I think it's worth, just before I get onto the bacteria bit, is to think about it as, if 20% of people have neurodivergence, then we are getting to a point where it's part of life's great rich tapestry. And so I think it's not helpful sometimes to say, you're autistic or you have ASD or not. We should think about it as a spectrum. For people more up the serious end, obviously, then that's perhaps a bit more different, a bit different. In terms of both the bacteria adjustment, I have seen those papers. I have seen some positive outcomes. What I haven't seen is any evidence at all that when you do reviews of these sort of data, that the overall push is that it's beneficial. So I think for an individual who's got ASD, if they want to explore that, I would say that or music therapy is absolutely fine, and it may really help some people. But I wouldn't see it as a panacea for, oh, I've got someone with ASD, here's the answer. What tends to work much better is, again, workplace adjustments. People with ASD are perfectly capable of doing many, many roles, but they may find other roles that are more flexible, that are sort of quick, where you need quick responses. They may find them more difficult, and they may find, for instance, being in very loud environments more difficult. So it's how can I adjust a workplace to take account of someone's nature, and I would say nature, rather than, can they work or not?
Great. Many, many thanks, Neil. Next question is, are there any UK papers that help employees who have anxiety in the workplace, bracket interventions, such as CBT?
I'm not wholly sure. So we absolutely know that if you're very anxious, and maybe to the point that you have an anxiety disorder, like generalized anxiety disorder, then CBT, cognitive behavioral therapy, is a really good intervention. There was a meta-analysis done recently looking at people who have anxiety disorders and who have CBT. And then once they get better, what's the chance that they would relapse? And obviously, there are lots of different sorts of anxiety disorders, but the overall relapse rate was 15%. So what that says is actually, if you have someone with an anxiety disorder, you get them to get to good therapy, you support them well at work. Through that, you make reasonable adjustments and they come back, you've got a pretty good chance that actually they're going to be able to get on and do their job. So yes, I think the overall message there is if you've got someone with an anxiety disorder, do get them the right help. And CBT is absolutely up there as one of those treatments.
Great, thank you so much. Just next question is from my side, if you don't mind. You kindly explained that any significant stressful situation in the workplace should be first addressed before we proceed to, for example, psychological interventions such as CBT, which is absolutely correct. But in the real life scenario, it's not easy. For example, if an employee is not getting on well with the manager, just to change the management line or things like that. Do you think in this situation, perhaps referring them to CBT could help them better manage the whole situation by using some CBT techniques when they are faced with a stressful situation? Or is there any benefit at all in this situation, or is it better not to do it at all?
No, that's a perfectly good point, Gabby. That actually, if you think, for instance, you've checked it out as the OH professional, they're not being bullied, they're being firmly managed, but that's okay because that's the situation. The manager treats everyone else reasonably, and the rest of the people get on okay. And for whatever reason, this relationship is not working, then I think you could do two things. I think one is you could offer the individual, if you can't move them and you can't move the manager, and that's not possible, you could offer them some coping skills because they don't have to like everybody. You just have to get on professionally. But you could also offer some either CBT coaching or some mentoring within the organization for the manager, because a good manager should want to get the best out of their employees, and maybe that so you can attack it, I think, from both sides. I think that might be useful. But yeah, there is absolutely a role for improving someone's ability to cope with stressful circumstances, as long as they're not ridiculously stressful and you think they're unreasonable.
Great. Many, many thanks. We're very close to 5 now. So if you don't mind, can I ask one more question, please?
Indeed.
I appreciate it. Many, many thanks. So the next one is, let me just find, and I think I have to go for something short, if you don't mind. I'm so sorry I cannot ask all questions. This one is, where can React and Stream training be accessed?
So React training within the NHS, there are, I haven't got a list of trusts, but we trained about 2,500 people within the NHS, including many people within what were the wellbeing hubs, to deliver React training. So if you're if you're working with the NHS, I would go to whatever the equivalent is now of the wellbeing hubs to see whether they have a trainer, because they could deliver that for free locally. That would be fine. I run a company called March on Stress. You're very welcome to get in touch. As I say, I don't really want to, there's a bit conflict of interest, and they provide trim training, but certainly we provide trim training. And if you put trim training into a search engine, I'm sure you will find other providers. But yeah, it is available out there.
Great. Thank you so much. Neil, you're a star in the world of occupational health and medicine, and many, many thanks for your ongoing support and this lovely presentation and all the answers to the questions. And thank you so much to all attendees in this webinar. Actually, the time is finished. It's 17 at the moment. Wish you all a wonderful evening and look forward to meeting you and seeing you again in the next webinars of this series. All the best.
Thanks very much. Thanks, Kevin.